Good afternoon, everyone. I'm Dr. Zori, second year postgraduate, and the topic for my today's presentation is comparative study of rapid antigen test with RT-PCR for the diagnosis of COVID-19. As all of us are unaware, this SARS coronavirus disease 2019 caused by SARS-CoV-2 have become a major issue worldwide since its outbreak in Wuhan, China in December 2019. SARS-CoV-2 is more transmissible in comparison to previously identified SARS-CoV and MERS-CoV. Coronaviruses are a group of enveloped viruses having a positive single-stranded RNA genome, and they are pathogenic. Now we will have a short glance on the genomic structure of SARS-CoV-2 virus. As we can see here, there are about 13 to 15 ORF genes in the genomic structure. The first ORF1A, 1B, ORF1, it comprises about 67% of the whole genomic structure of SARS-CoV-2. This ORS further encodes for 16 non-structural proteins, four major structural proteins, and 6 accessory proteins. We will be discussing about these genes in RT-PCR as they are used for the target genes. In this COVID-19 pandemic, a reliable, early, and accurate diagnosis is very crucial for timely medical treatment and also to contain its spread in order to save lives. On 14 June 2020, ICMR introduced antigen detection assay for point-of-care diagnostic tests in combination with the gold standard RT-PCR. In this particular study, we will be comparing the sensitivity and specificity of rapid antigen tests with RT-PCR. Aims and objectives of my study are to compare the sensitivity and specificity of rapid antigen test with RT-PCR for the diagnosis of COVID-19, to determine the sensitivity of rapid antigen test with reference to CT value of RT-PCR, and also to evaluate the performance of rapid antigen test in symptomatic COVID-19 patients based on duration of their illness. Clinical specimens, a total number of 594 nasopharyngeal samples were taken from healthcare workers and their families who were in first contact. Both symptomatic and asymptomatic patients of all ages were included in my study. The study was conducted between September to November of 2020, and all the samples collected were subjected to both rapid test and RT-PCR irrespective of their results. Rapid antigen test was performed by using the standard Q COVID-19 antigen test kit, which is a qualitative test for the detection of SARS-CoV-2 nucleocapsid antigen. It is a rapid immunochromatographic assay, and the result interpretation was done after 15 to 30 minutes, results showing positive, negative, or invalid, depending on the control test line, which is seen in the test strip. RT-PCR. Viral extraction was first performed from 200 microliter of the nasopharyngeal samples, which were collected in VTMs. RT-PCR was done to target E gene as the screening gene and ORF1A, and N gene as the confirmatory genes. All the procedures were performed as per the manufacturer's instruction, and the result was interpreted as positive and negative by considering cycle threshold cutoff value less than or equal to 35. Now coming to my results. From the total 594 samples which were collected, among these 10.5%, which is 65 samples, were true positives, and 11.7%, 70 samples were false positives, and true negatives were 459, and there were no false negative results. Now, if we see the results of both the rapid and RT-PCR assay, the sensitivity of this rapid test comes out to about 48.1% with 100% specificity, and also showing a negative predictive value of 86.7% and a positive predictive value of 100%. If we compare the CT values with the rapid antigen test, CT values of less than or equal to 24 have higher sensitivity of about 79.3% in comparison with the high CT values of more than 24, which have a sensitivity of 24.6%. Among the symptomatic and asymptomatic, the sensitivity of the rapid test also differs. Symptomatic patients shows sensitivity of about 50%, whereas among the asymptomatic, the sensitivity was 40%. In both the patients, the specificity was 100%. In reference with the duration of illness in symptomatic patients, again, the rapid test sensitivity differs. In less than or equal to 5 days duration of symptoms, sensitivity comes to about 58.5%, whereas it was 19.3% in more than 5 days duration of symptoms. Now coming to discussion. In my present study, I found out that the rapid antigen tests have low sensitivity of only about 48.1%, which in comparison with other studies done by Gupta et al. And also by the manufacturer, which was about 81 to 84.3%. A study recently conducted by Sumaya et al. Also shows low sensitivity of 23.8%. Whereas the specificity of my present study is 100%, which corresponds with the manufacturer's report and also by Gupta et al., Sumaya et al., and Porte et al. In the present study, the test sensitivity greatly improves with high viral load, which is CT value less than 24, which is consistent with other study conducted by Gupta et al. And El Porte et al. Also, good sensitivity of about 80 to 85.5% were reported by Gupta et al. And Sumaya et al. Among symptomatic patients within 1 week of illness, whereas our study shows 59% sensitivity. Among asymptomatic patients, also good sensitivity was reported by other studies conducted by Gupta et al., which was about 69.2%, whereas in my study, the sensitivity was only about 40%. Coming to conclusion, the rapid antigen tests have shown comparable specificity with RT-PCR assay, whereas those with negative results have to be confirmed with the gold standard RT-PCR. Now I have concluded my topic with this, that the rapid antigen test can be useful as screening assay, especially in high prevalence region and also in areas where there are limited access to molecular diagnostic methods. Here are my references.